All right, so moving on into ENT part 1, this is mainly going to be concerned with the infectious disease aspects of ENT, right? So again, we just talked about all the antibiotics. We're going to talk about how we actually use them clinically in some of our patients, right? So again, we talked about a lot of different antibiotics. We're going to find, depending on the organ system, there's going to be certain ones you just use more commonly for that particular organ system than others, right? So we'll see things like amoxicillin, augmentin, Clinda as a backup drug, like Rocephin. A lot of these are going to be very common to ENT. You may not see them as prevalent in other disease, organ systems potentially, but we'll look at that as we go along. Cover those on. All right, so let's look at the ENT antibiotics. Starting off with acute otitis media, very frequently, what's causing the problem here? Strep pneumo is a big one, right? So we see here, if you're actually looking at, and again, I'm not going to get into specific all the epidemiology and all of that when we actually get into the organ systems and the different disease states. I will get as deep as I need to as far from a pathophysiologic standpoint, so that way we're at least on the same page as how these disease states work, how they actually cause disease, what is the likely causative organism or the causative or whatever the cause is for the disease, and then that way we can understand why we use what drugs we use and how they work to treat that disease. Okay, so again, I'm not going to go specifically into this is the rising cases of AOM or I don't care about that, right? It's not for our purposes here. You get that in other classes. Anyway, you see a lot of strep pneumo from a bacterial standpoint, right? And again, if you look at this, and this is straight from the Sanford guide, you're going to find that, oftentimes there's going to be virus kind of co-infecting here. So, and again, about 66% of those cases, there's a bacteria plus a virus. They're very common. However, when it is bacterial, strep pneumo is a big cause right here. What else? Marxella catarrhalis. H flu, right? Haemophilus influenza. Those are the three big ones that are going to be causing disease here. Now, again, you may find the etiology changes over time, right? So, again, if you have vaccinations occurring here against H flu, that may go down as time goes on, as you'll see, right? And again, depending on if you're dealing with a pediatric patient versus an adult patient, you may find that it tends to skew a little different. Either way, right? Resistance patterns can change, which bugs are present may change a little bit, as you'll see. But anyway, mainstay of therapy, how we're going to actually treat this. Let's look at this, right? And again, if there's any discrepancies between your CMS course, bring them up. We can talk about them, right? Because again, we all have different perspectives. It's not like there's an absolutely one right answer, one wrong answer. We can talk about it, right? Sometimes I make mistakes, they make mistakes. Everyone's human around here, right? Anyway, mainstay of therapy, acute otitis media can be sometimes very difficult to penetrate and get into all that tissue, right? And again, like you think about it, what's kind of the best way to get rid of that infection? To physically get rid of it. Just cut it open, right? And just get rid of all that pus and all that gunky stuff, right? Because again, usually that AOM probably developed because they're eustachian tube dysfunction. They can't drain it out anyway. That'd be one of the best things. But it can be very difficult to actually penetrate that tissue and get into all that fluid. So very frequently what we use is shooting to use higher dose amoxicillin, right? So again, I'm not going to have you specifically remember the exact dose on the test, but just know that high dose amoxicillin is needed in order to really penetrate those tissues there to make sure you get good antibiotic levels in order to actually treat that and get rid of that infection, okay? That make sense? Anyway, also the other benefit here is that by using higher levels, you get better coverage against potentially resistant strep pneumo. We mentioned that you can either use a different drug if you have a resistant bug, or use higher doses. In this case, amoxicillin is pretty well tolerated. I can drive that dose up pretty high, and besides some nausea, vomiting, diarrhea, I'm probably not going to see a lot of issues with it, right? I'm not going to see things like Stevens-Johnson's regularly or hepatic dysfunction, etc. Okay. Now, if it's say severe, like patients coming in, they just look sick as snot, or if you know to be resistant disease, say for instance they've been on antibiotics previously in the past month, this is where you need to step it up, right? So this is where I'm going to add on what? Beta-lactamase inhibitor, right? So I'm using amoxicillin still, but now I'm adding on a beta-lactamase inhibitor. You may say, well, amoxicillin already failed. Why use amoxicillin again? That beta-lactamase inhibitor makes all the difference, right? So you really start to increase that coverage there. Resistant strep pneumo may now be susceptible to this combination. This is a good combination to use here, right? So you can bump it up, use augmentin. Now, again, if you have someone who comes in, their first case of acute otitis media, they've never been on antibiotics before in their life, you don't have to go to augmentin, right? You can start with amoxicillin. It's going to be fine. You don't have to go with that big gun unless you really need to, okay? Of course, the question is, well, what happens if my patient cannot use a penicillin? What do they use as an alternative? And so this is where this comes up, right? And so you notice cephalosporins are very frequently recommended as an alternative if patients are allergic to penicillins. Now, the caveat is that the patient had a true blue anaphylaxis allergy to a penicillin. You want to be cautious, right? You won't want to necessarily, push the envelope, so to speak. If you're really concerned about it, you could, one, give a test dose in the ER or the urgent care center, wherever you're at. You could do that, see how they tolerate it. Give them an hour or two. If they fly, you say good to go, and we send you off with your prescription. Hopefully you'll clear that infection, right? Otherwise, if you want to, you can use an alternative. But things that we use as alternatives are usually going to be developing more and more resistance, right? So in this case, as an alternative, we could use something like ceftonir, right? Or Omnicef is the brand name there. Remember what category this fell into? It's a cephalosporin. Remember what generation? Third generation cephalosporin, right? So again, this is using, those we're kind of bypassing the first generation. We're getting a little bit bigger as far from a gram-negative sort of coverage standpoint to get that H flu, to get that moxicillin catarrhalis. The problem though is that if you don't use Omnicef, then you can use something like azithromycin. However, we're starting to see a lot more strep pneumo resistance to the macrolides. So you may run into the case where if a patient has a true blue penicillin allergy and say, hey, I don't want to use ceftonir for this patient, I want to go with azithromycin, you may find it doesn't work, right? So if they don't want to improve in 3 days or so, they need to come back in and get something else, right? Because we know that's not really going to be good coverage from that standpoint, okay? Now, as far as treatment duration goes, what's the optimal time? We may not have that exact answer. We do think that around 5 to 7 days should be pretty sufficient for most patients. You may need up to 10, especially if it's more severe. 5 to 7 probably isn't going to be good enough, right? So again, the more sick they look when they come in, probably more likely are to recommend something like a 10-day treatment course versus 5 or 7. Come in, it's pretty minor, first time, 5 days may be okay. However, if they look more sick, then longer is going to be warranted there, okay? Sound that jive with what you know so far, hopefully? Or repress that lecture already. Now, I did make a boo-boo on this slide, so please note my strikeout and strike it out of your notes as well. If you fail therapy, so say the patient comes back in, they've had no improvement in 3 days, what do you do for that patient? Well, if they haven't had any antibiotics in the past 3 months, you can start off with something like Augmentin, right? So again, if they were on amoxicillin initially, they didn't respond well in that 3-day period, you can start them up on Augmentin, right? Or you could do something like a third generation cephalosporin. Ceftonir would be a fine option in this case here, okay? So again, you're going on a stepwise approach. You don't want to start with the third generation cephalosporin. You want to build up to that, right? It's kind of like a magician. You don't start with sawing the lady in half right off the bat, right? You got to start with a few card tricks, something like that. You got to show just a little bit at first and then build up to the big tricks, okay? On the other hand, though, you may escalate to more parenteral therapy, right? And right now, all we've talked about is oral therapy. Ceftonir's oral agent, amoxicillin, Augmentin, those are all oral agents. You can actually step it up and then go parenteral, which when I say parenteral, what does that mean? IV, IM, sub-Q, anything like that, where actually I'm injecting a needle into the patient, that's a parenteral therapy, right? And so in this case, you can bump it up to something like ceftriaxone. Ceftriaxone, what category does that fall into? Third gen cephalosporin. It's a very good drug. Also, remember, how often do you have to give ceftriaxone? 1 time a day, which is really nice. That's a good long half-life. And so in some cases, what you can actually do is have the patient come in, and they'll get 3 doses of it 24 hours apart. So come in, get 1 dose, because again, this is not something you typically would give to the parent to administer. You do it in the clinic or in the ER, wherever you happen to be. Again, at some point, you have to question, like, well, do I need to bring this patient inpatient? There's some cases we have to do that, but if you can keep them out, then IM Rosefin is going to be a really good option for those patients, right? The benefit of using parenteral therapy is you're going to be guaranteed to get good systemic levels, right? If I have a patient who's got AOM, maybe they have some vomiting going along with that, maybe they're not getting that full dose that they should be getting, it can be problematic, right? So IM Rosefin is a very good option for those patients, okay? Now, beyond that, things get a little bit more complicated, right? That's where you have to look at things like maybe a fluoroquinolone. Maybe we're not going to get into that. We want to know kind of the first line therapy, what to do if they're allergic, and then what's kind of the backup if the initial therapy fails. Okay, that's kind of what we're going to be looking at predominantly, okay, for these infectious diseases. Again, I wrote down bicillin here. This is actually not recommended. I don't know why I put that there. Sometimes you look back at your notes and you're like, was I in a fugue state, or was I someone pumping knockout gas in my room or something? I don't know what. Anyway, that's incorrect. You should take that off of there. We'll not cover that. Up next, we have acute bacterial rhinosinusitis. You typically see the same bacteria as acute otitis media. Those are still the 3 same most common ones: strep pneumo, H flu, and moxicillin catarrhalis. However, you tend to have a little bit wider spectrum of bacteria that could also be causative here. So you see things like strep pyogenes, Staph aureus, some gram-negative bacilli potentially, and so that can augment how you're going to be treating this to some degree. We're going to see a little bit of a change here. Now, the big thing is, when do you actually treat rhinosinusitis? Because more often than not, what is the cause? Viral, right? So again, you don't want to treat right off the bat. You typically wait till what? 10 days. They got to be sick for a while, right? So they need to have, like, usually they have a resickening that occurs 5 to 6 days in or so, where they actually get sick again. It may appear they're getting better, and then they get sick again. So that tends to be when you kind of decide, yes, this is most likely going to be bacterial. Yes, I want to go ahead and treat this. Now, again, here, because we know that amoxicillin is typically going to be inferior as far as treatment goes for rhinosinusitis, we actually just want to go ahead and start with using a little bit bigger gun. So here we're going to bypass amoxicillin, go straight to Augmentin. Okay, so first line therapy for rhinosinusitis you believe to be bacterial should go with Augmentin here. Again, a lot of that is due to the fact there's a high instance of beta-lactamase producing H. influenza. Okay, so that means if I were to just give amoxicillin and it happened to be H. flu, guess what? It's going to be inactivated. It's not going to be any good. So I want to go ahead and start with something that has a beta-lactamase inhibitor already involved with it. Okay, so that's why we're going to go with Augmentin here. On the other hand, if I have a penicillin allergic patient, sometimes you're going to need multiple drugs in order to get the same sort of coverage. So in this case, I could use something like clindamycin, which we said is good for what type of bugs? MRSA, so it's really good for gram-positives of all stripes. And what else? Then anaerobes, right? So again, we're not really thinking anaerobes quite so much as being a causative organism here, but we are going for the gram-positive coverage, right? Namely that strep pneumo, and potentially if MRSA is involved or MSSA, this will definitely get that. And then you can use it plus something like cefixime, right? Another cephalosporin you can add in to get that additional coverage. That'll get some of those gram negatives. That'll get some of that H flu and whatnot. Or alternatively, if you don't want to use either of those two, right, you could use something alone like levofloxacin. We mentioned levaquin is good for upper respiratory tract infections because it's a good wide coverage. However, remember resistance is a problem. Okay. Also remember the age considerations. You may not want to use levo for a young kid. Maybe I'd rather use something like clinda and cefixime, right? Or if my patient has a history of C. diff, maybe I don't want to use clinda. Maybe I want to go ahead and use levo instead, right? So these are things you have to consider.
I think also in our ENT class you said doxycycline. Do you know why we use that?
Doxycycline can be a consideration here. It will have very similar coverage to the levofloxacin. Doxy I don't see being used as much, probably due to concern from especially like little kids. If you had someone less than 8 years of age, you'd worry about what? Discoloration of the teeth, things like that, And again, it just depends, and where you're working at can have an influence too as far as resistance patterns go. So doxy would not be a wrong answer here as well. Levaquin, again, I'm trying to limit the scope of every antibiotic you could possibly give just to some of the more common ones you're going to see, and Levaquin tends to be one of those, right? Now, as far as treatment goes, what do you notice about the treatments here? Yeah, it tends to be longer for kids, right? So kids are just kind of natural little cesspits of bacteria and things. So we want to treat them for a little bit longer to make sure we really eradicate that. Versus the adults, maybe 5 to 7 days is going to be sufficient for them. But kids, usually up to 2 weeks is going to be useful there. Now, as far as additional therapy, and we'll talk about some other ENT stuff in the second part once we get out of the infectious disease stuff, they've actually found that saline irrigations can be pretty useful, right? So again, using like a neti pot or using any kind of nasal rinse tends to have some efficacy in trying to kind of clear out the sinuses and kind of help with getting rid of some of that bacteria. So again, even if you don't give them any antibiotics until they're sick for that 10 days, give them some, recommend some saline rinses. That'll be totally fine, right? Now, of course, anyone know any problems with using saline rinses? Yeah, what's the matter with using things like tap water? Amoebas, right? So again, don't use like your retention pond water or anything like that. Because here in Florida, it gets warm enough where you have things like Naegleria that can actually form. And so it's rare, but it has occurred where people get these amoeba infections. They'll cause a meningitis, and once that happens, that patient's dead pretty much, right? So you got to be careful with that. Make sure they're using the appropriate stuff, using it according to directions. Acute pharyngitis. What's usually causing acute pharyngitis? On the slide. Oh, yes, ma'am.
Wait, going back really quick.
Yep.
Is the levofloxacin also with the clindamycin?
No, that one you could use by itself. So that was the distinction there. You could use clinda plus cefixime, or just use levaquin by itself. Okay. Because again, levaquin is usually going to have pretty good gram-positive coverage. You don't need the additional clinda there to cover for that stuff. Okay. Now with acute pharyngitis, very frequently it's going to be viral, right? However, if it's going to be bacterial, it tends to be group A beta hemolytic strep. So group A strep is the most common cause here from a bacterial standpoint. Now, we actually don't care about the infection itself. We don't really care about actually clearing that because, again, you don't see a lot of issues from the bacteria. The problem, though, are going to be the suppurative complications of strep pharyngitis, right? So this is where you can see things like rheumatic fever, is where you see other complications that can develop here, which I'm sure you've covered in the ENT section, so I'm not going to belabor here. But the main goal is to try to prevent that. So what we'll do very frequently is we will now institute in a lot of places these rapid strep tests, because before it was very frequent to over-prescribe antibiotics for this when it was mostly viral. So oftentimes what we'll do, and this is kind of more of like a kid's disease specifically, but we will go ahead and we'll do a rapid strep test. And if it's positive, then we know, okay, we have a positive strep here, we're going to go ahead and treat. If it's negative, we'll oftentimes do a follow-up culture because we know that that test is not going to be perfect, right? And when we get into EpiBio more specifically, we'll talk about specificity and sensitivity of tests. We're going to realize that that's a case where you could have many false negatives on that test. So because of that, we'll go ahead and do a follow-up culture. And if it's negative, we'll send the patient home with nothing. And then if the culture comes back positive, we'll call them up and phone them in a script for amoxicillin. Okay. And again, the main treatment here is going to be amoxicillin. This is actually nice because we mentioned amoxicillin is a time-dependent or concentration-dependent killer. Time dependent, right? So you typically think about giving it more frequently. In this case, we can actually just give it one time a day. So it's nice from that standpoint where you just do one time daily treatment for 10 days, and that's all the kid needs, right? However, some of these kids have a really hard time swallowing, may not be able to tolerate oral medications very well. This is why, as an alternative, we could do something like a benzathine penicillin injection. This is where you just do a one-time IM shot and you're good to go, which is very beneficial from that standpoint. Now remember, which routes can I give that bicillin, that benzathine G penicillin? IM's on there. Is there any other routes I can give it? Can I give it IV? I can give penicillin G IV, but I won't get the nice long-acting effects of the bicillin. Why don't I want to give bicillin IV? Yeah, remember it's in that nice, like, milky sort of base there? That can cause an embolism if you were to inject that IV, right? So you don't want to do that because all that, those big lipid molecules that can cause an embolism. So that's one thing there. Occasionally, if patients are allergic, truly allergic to penicillins, we could use something like Keflex, which is what generation cephalosporin. The first generation that could be useful. Clindamycin could be used potentially, or zithromycin. Very rarely do we need to do that, but occasionally it does come up. Right, so Keflex is probably the more common one we'll use in those cases. Okay, so moving in, next we have otic antibiotics, right? So these are going to be things we're using specifically in the ear. Now keep in mind when we're talking about different dosage forms, as far as otic and ophthalmic, because again, after ENT stuff, we're going to get into the ophthalmic. What's the rule as far as using products between the different areas? You can use eye stuff in the ear. You cannot use ear stuff in the eye. Okay, the eyes are very sensitive to tonicity. They're sensitive to pH. They're sensitive to all those sorts of things. Eye stuff has been perfectly balanced to go in the eye. The ear, not so. It's not as what I'm thinking of. It's not as persnickety about what it gets put in there. So again, you can put anything in there, right? So it doesn't really matter because again, it's not very sensitive from a tissue standpoint. So again, ear stuff cannot go in the eye. Eye stuff can go in the ear, right? And that's important because why would we ever need to do that? Why does that make sense? Or does that matter? Cost can be a big deal, right? So again, if the ear stuff is exceedingly expensive, my patient doesn't have good insurance, I can use eye stuff. Sometimes that's cheaper. What else? That's less. I've not run into that, so I wouldn't think of that necessarily as a big one. Think about drug shortages, right? So again, that's something completely out of your control. But if you normally do something like Ciprodex for an ear infection, all of a sudden the company or the pharmacy calls up and say like, we can't get this. No one in town can get this. What do you want to use instead? You got to have a backup, right? And so this is where we'll use an alternative agent, sometimes an ophthalmic drug in the ear, in order to treat that, right? And again, no pharmacist should give you any guff about that because they're very familiar with doing that as well, right? So anyway, so when looking at the otic medications, very frequently we're going to be mixing an anti-infective along with a glucocorticoid. So what benefit does that provide? What do glucocorticoids do for us? Deals with the inflammation, right? Because again, ear infections, they hurt. Like there's a lot of inflamed tissue there. It gets very swollen. It's not, not very comfortable for the patient. So very frequently, we'll give an anti-inflammatory like a glucocorticoid into the ear that will deal with that inflammation, and then that will allow the anti-infective to actually get in there and treat the infection itself, right? Because again, normally you think of glucocorticoids as doing what to fighting infections? Normally detrimental, right? Because again, it's immunosuppressive. However, because in the ear we're getting very high concentrations of that stuff, it doesn't really matter. We don't need our own host immune system to fight that off. We can just give the antibiotic and it's basically going to take care of it. Okay, so it's kind of the big differences with those. Now, as far as available agents go, you can either get something like a fluoroquinone, like ciprofloxacin by itself. Sometimes it'll come in a combination with ciprofloxacin and dexamethasone. That's called Ciprodex. This one's very commonly used, and again, it's nice because you don't have to give them many drops. You just give it twice a day. It's real expensive, though. It can be hundreds of dollars if the patient does not have an insurance that will cover it. So because of that, this can be pretty cost prohibitive for a lot of patients, and again, if they can't afford it, they're not going to take it, right? They're not going to buy it because again, that could be their whole, money for rent or groceries or whatever that month. They got to make their choices, right? So sometimes we'll use other cheaper agents, things like neomycin, polymyxin, and hydrocortisone. Again, hydrocortisone being the anti-inflammatory. That's a corticosteroid, and then we'll have polymyxin and neomycin being the two anti-infective agents, right? So again, those are going to be what kills off the bacteria. Now, did Professor Q mention anything specific about utilization of cortisporin in the ears? Any specific cases where you do not want to use it? If you have a tympanic membrane rupture, or if you have tubes in, that's the other case, right? What's the problem with that? So neomycin is probably more than likely can cause hypersensitivity. That tends to be the more problematic one as far as causing an allergy and causing dermatitis. That can be one issue. But more specifically, remember we were talking about polymyxin B? We mentioned that can be very dangerous when being used systemically because of all the ototoxicity. Ototoxicity is one of the big problems you can see with that. Polymyxin can damage the hair cells in the cochlea. You don't want that, right? So polymyxin B is a big thing. So if you have any kind of rupture, or if you end up having tubes already in place, not going to be good for that, right? Yes, ma'am. I don't. It's really more the polymyxin B. I think the neomycin is really going to be more from the hypersensitivity sort of standpoint. Oftentimes, though, the problem is that those products are not sold separately. So sometimes it's like, well, is it one or the other? Could it be a combination of the two? Who can really say? But we definitely know that when we get polymyxin B by itself systemically, you do see ototoxicity, very similar to aminoglycosides, similar to other agents that do the same thing. So for sure, polymyxin B does it. Does neomycin play a role? Who can say? But at least from a hypersensitivity standpoint, neomycin is usually a problematic one there from that standpoint. Okay. And again, sometimes you have ofloxacin by itself. It's kind of an early generation sort of fluoroquinolone that'll be used pretty frequently there as well. Oftentimes what we'll end up doing is we'll use ofloxacin for patients whose insurance do not cover Ciprodex. We'll actually use ofloxacin otic, and then we'll use the ophthalmic dexamethasone. Dexamethasone is another anti-inflammatory you see here that we can just apply that. So they're having to use two different droppers. Not great from a compliance standpoint, but again, it's better than them having to pay $300 out of pocket for Ciprodex, right? No one wants to do that. So it just depends on what their coverage is going to include here. Trying to think if there's any other big points with that. Oh, some people think that there's a concern if you did have like a ruptured TM that also when you think about wound healing in corticosteroids, what's the interaction there? Slows it down. So some people are concerned that dexamethasone in those cases could slow down healing of the TM. Clinically, I don't know if that's really all that important. That ever has come up to be a big problem, but some people have that concern. But very frequently, we have a lot of kids coming out of our surgery for tympanostomies being placed. They come out, they get put on Ciprodex or Oflox/dexamethasone for a couple of days, and they're usually good to go from that standpoint. So if our ENT docs really aren't that too concerned about it, I'm probably not too concerned about it either from that standpoint, right? Okay. I'm out of time. Sorry, I went 1 minute over. Do you have any questions I can answer before I let you go? If not, I will see you guys next time.